Death and dying are inevitable in humanitarian crises. However, the ethos of humanitarian action tends to focus on life-saving, which may lead to neglect of those suffering with poor prognosis. Since 2016, growing attention has been placed on the possibility and importance of integrating palliative care in crisis responses. To define, palliative care alleviates physical, psychological, social, and spiritual suffering of patients with life-limiting medical conditions, as well as supporting their families. Humanitarian crises are large-scale events that cause massive loss of life and breakdown of society, with examples including war, natural disasters, and epidemics.
We heard very sad stories about people who were shunted to the side, left to die at the back of a clinic by themselves, and not receiving the kind of treatment that they would get in ordinary circumstances, whether surrounded by family or healthcare providers. So we started to look at what was going on there and what were the obstacles, the advantages to doing it. And I think we found that there was a strong interest from humanitarian aid organizations. They needed some way to think about how they could prepare policy guidelines and protocols for providing palliative care. And that sometimes palliative care and discussion about end-of-life care is equated with either disposing of or neglecting. It can be equated with euthanasia. And because of that, it's a hard conversation to raise. Realizing that those tensions existed was pretty important.
To address physical suffering, opioids are the gold standard for managing pain in disaster contexts. A 2018 study strongly recommends, with high confidence, the use of opioid analgesics to reduce pain among patients with the Ebola virus disease. Research indicates that for patients and families, a dignified death includes adequate pain and symptom management, as well as clear communication and decision-making from healthcare providers. Endorsed by the WHO, psychological first aid is an effective response strategy during humanitarian emergencies. The main components of PFA include listening to and emotionally calming disoriented survivors, contacting support persons, and providing information about stress and coping. For refugees, the integrative adaptive therapy is a short-term psychological intervention that helps to identify their emotional responses towards forced displacement and human rights violations, as well as develop resilience to changing environments. Psychosocial and spiritual aspects of palliative care are critical in end-of-life care. Humanitarian healthcare workers reassure the patients that they are loved and will be remembered, as well as provide them space to discuss any feelings of worry, guilt, or regret. Simply sitting with patients, holding their hand, and talking to them conveys solidarity and promotes a dignified passing. Prior to 2018, standard triage categorization in crisis responses does not involve palliative care, and it indicates that expectant patients require less attention and resources than those with minimal injury. In 2018, the WHO recommended a revision to this standard, in which expectant patients are placed in Category 2A, a higher priority category with the requirement of palliative care.
I've also seen palliative care do remarkable things that help them manage their pain, their anxiety, even just to have access to a phone call so that they could call a family member who was not with them if they were refugees or displaced in some ways, to be able just to say their goodbyes. These are simple things that can easily be accounted for in a humanitarian setting. It doesn't have to be expensive endeavors that take a lot of energies. Sometimes it's just the smallest things that can make all the difference.
This past year, I was working in a Rohingya refugee camp in Bangladesh for about 10 months. And I was working as a nursing manager in the neonatology department, which is focused on care for newborn babies. My role was primarily around training the local staff, the local nurses and doctors and members of the health promotion team and other staff around what palliative care is and what we can offer the patients. Access to medications, especially controlled medications like morphine. We didn't have a license to import morphine, and there was only one company that produced morphine in the country, and my organization had some concerns about the quality of that supply. and just our ability to access it was challenging. What we're trying to do with palliative care is to really focus on what we can do for the family and for the child. One thing that my colleagues have been talking a lot about is the importance of an anthropological assessment or an understanding of the context. We need to understand the beliefs among the staff and also in the community around death and dying, how they perceive it, what's important around that time. In a humanitarian context, it's so clear there are huge cultural differences, and so you need to understand that. We sometimes forget the diversity of our patients, what people want, what people value. It can be more complex in a humanitarian context.
When we started doing this work, there was hardly any discussion, but there was a sort of a growing interest in the humanitarian sector to raise the value of including palliative care. I think it had always been there simmering at the background, but it became particularly salient around the Ebola crisis in West Africa. Looking at what's happened in the space of time between when we originally began our study and now, there's going to be more data there. And what we're beginning to see are things like not just academic articles, but also guidelines, guidance statements, advocacy statements about better access to things like opioids in the field, statements from organizations like either Sphere, ALNAP, and definitely the World Health Organization, who have created policies guiding access to palliative care in humanitarian action. There will inevitably in every crisis setting be people who will die. And so not providing them with the care feels like an injustice that needs to be responded to. Support for somebody dying is probably one of the most important aspects of respect for their dignity and respect for their lives as they lived them. Where COVID became an issue in places like refugee settings, low and middle income countries, it was that much clearer that when we're faced with pathogens that we have no treatment for, where there wasn't even enough critical care resources available in given settings, that simply saying to people, well, we have nothing to offer you, and sending them home would not have been enough. We have to be able to have something to offer, and we always do. Palliative care can help to bring more appreciation for the work that humanitarian practitioners are doing, so that people understand that we may not have been able to save a life, but at least we could provide the softest landing.
There is increased attention towards understanding why it is critical for humanitarian workers to respond compassionately to the needs of patients with low likelihoods of survival, as well as how to plan for, deliver, and assess these practices. Despite the recent establishment of official guides on palliative care and humanitarian action by international humanitarian organizations, a scarcity of data remains on evaluating the practical integration of such recommendations in disaster settings. More epidemiological assessments of needs and clinical trials of palliative care interventions are needed to translate policy into accountable action. In addition to saving lives, the relief of suffering for people who are severely ill and dying must be enabled during a humanitarian response. Even when seemingly unlikely, there is always something to offer.